let's say 100 inpatients at the two facilities, maybe 120 at the two facilities. We'd furloughed folks. We weren't seeing a lot of surgeries. We had reduced staff and footprints because of the concerns about COVID. And we basically, like many of you, we'd reduced our economic interface for the community. We had 3 inpatients. Today we have over 50, and we have just blasted into the stratosphere with COVID inpatients. I had a 12-hour hospital shift last weekend. I took care of 24 inpatients, and 12 of them were COVID positive. Right now, about 35% of all the patients in our hospital system are diagnosed and really sick with coronavirus. So it's been a substantial impact, and really we're operating at 110% intensive care capacity right now.
Wow.
How can you have 110%? Well, we have overflow patients on ventilators and in critical care beds in both our post-operative areas and our emergency department. So we are stressed. We're making it do. I mean, we're not. I don't want to scare you with this, but I'll tell you, our limiting factor is not the room and the space. It's person power. It's personnel. When you get an old person like me having to work 16 hours on a hospital shift, I'm glad and honored to be able to do it, but it's challenging. And so we've actually had some National Guards folks come in over the past couple of weeks to help us out. And it's almost like a mini hurricane, which, many of us have experienced before. So I say that not to scare you, but to let you know that we're taking this seriously. And thank goodness our contingency plans have been adequate so far. It's good to see that I'm working with a good community and a bunch of bright leaders that has had the foresight and the talent to make this work right now. And it's a community effort. It's a team sport. I want to speak well to everybody in our community and how they've all stepped up. That's a sermon. I'll pass the plate later, but I want you to know it's an honor to be here and glad to share any information we can with you. Thanks.
So I think, one of the biggest things that is happening now is this big thing about, do I mask and do I not mask, and what the importance of it is, and just want to hear your thoughts as a frontline individual as to, about the mask debate. Well,
a good question. I started wearing my mask everywhere, basically about a month or so ago, when it became apparent to me that I should be a role model for the community. At the national level, the Surgeon General, who's a long-term friend of mine up in Washington, and I knew him before he was famous, so to speak, as an anesthesiologist out of Indiana. Jerome Adams, he was pushing for masking at the federal level. Most of the leaders in the country and the state medical leaders are recommending universal masking. And so, I started wearing my mask everywhere, and I would go to various community areas. I might even been in some of your arenas when I was visiting your establishments. I put my mask on when I got out of the car. And when I go to restaurants, I wear the mask to the table. And I noticed that Linda and I, my wife and I, might be the only people other than the employees. Now, the employees, the businesses were absolutely good at wearing the mask. They had masks. All the wait staff in the restaurants, all the retail clerks in the retail establishments, they're wearing their masks. They're maintaining social distancing. They are role models for the economy and the community also. But universal masking, all of us need to do it. It's easy. We can control this. It doesn't necessarily protect you from getting the COVID cooties, as I call them, but it protects other people from you spreading it to them. And whatever droplet forms you might be coughing, sneezing, speaking, talking a lot, as some of us are wont to do. So I've got a bunch of masks. I've got your standard paper mask that we wear, the surgical mask, and that's a good mask too. It's got a little pipe cleaner like wire or something in it that allows it to fit. I've got the N95, which is the one that we wear as healthcare providers in an intensive care environment when there's a lot of aerosolization of the particles. It's a lot smaller than you would see in the normal environment. When I've got folks on ventilators, they're using nebulizer treatment, so this is a tighter mask. And then I've got, the cloth mask, which is a good one. You can use it as an advertising, as a sports logo. So all the masks work. The cloth mask work, the paper mask work, the surgical mask, the N95s. What doesn't work is a bandana, a light bandana, something that a biker might wear to put on his or her head. Those bandanas don't work. They don't filter out the particles, the what we call the droplets, air droplet, the water droplets that spread the COVID-19 virus. So you really need to have more than just that. You need to have almost a 2-layer cloth mask. You can get them color coded. It becomes a fashion statement. You should wear them all the time. Children should wear them. My grandkids are used to wearing masks when they're in the car with me. And they say, oh, gee, Daddy, do we have to wear a mask? Yes. And then even they start saying, we've got to because gee, Daddy's a doctor. We all have to wear a mask. We wore them last night when I had 6 granddaughters and their friends out with us, or my 4 granddaughters and a couple of friends. So yeah, wear the mask. Critically important. It clearly makes the spread of the virus attenuate, and it's important to do that.
Thank you. So hand sanitizers, we had a question submitted that what are the 6 hand sanitizers we should not be using?
Well, that's interesting. I don't know of, when you say not, I'll tell you what you should do, because I'm not going to be able to rule out all the non-valuable hand sanitizer. I carry one with me all the time. I've got a spare one in each pocket. I've got the spray type, which is good because then you can spray your phone, your instruments, whatever, when you hand it over. I do a lot of media these days, so when I get mic'd up, I spray the microphone before I give it back to the journalist or the reporter. And then you've got the liquid kind of, they need to be about 60 to 70% alcohol based. That's critical. Chlorine based, Clorox based is good for surface decontamination. But I don't think it's good to put Clorox on your hands. So be careful when you talk about sanitizers, topical sanitizers. Some are for surfaces. I use some to wipe down my stethoscope, to wipe down the laboratory surfaces, to wipe down tables and all. Those are typically not as much alcohol based as chlorine based. So, but the chlorine based are pretty caustic for your skin if you think about it. That chlorine, that Cl molecule, not to make a scientific lecture out of it, but Cl is chlorine. That's the chemical sign for chlorine. And you mix it with hydrogen, then you got hydrochloric acid, and hydrogen's everywhere. So you want to be careful with that Clorox-based and chlorine-based decontamination. We've had folks, if you recall early on, that apparently tried to drink some sanitizer to kill the virus in the system, where they died of chlorine poisoning. So try to avoid, use alcohol-based sanitizers if that makes a difference to you. Okay.
So Kathy Bessie submitted a question, Dr. Harmon. How do you respond to people, in parentheses, the skeptics, who say the numbers provided by hospitals are inflated?
Well, here's what I think they're thinking of. You can have COVID as a coincidental illness, and that's what we as doctors are being very scientific about. Let me give you an example. One of the patients I admitted this past weekend had fallen and broken a hip. This patient was 99 years old. He was in an assisted living facility and had slipped and fallen and broken a hip. Now, the patient was in an assisted living facility that unfortunately had an outbreak of COVID a couple of weeks ago. And so when we tested that individual was COVID positive, but absolutely, believe it or not, at 99, asymptomatic. So the patient was admitted to the hospital with a positive COVID test, but not because of the positive COVID. So when we talk about a COVID patient, and you talk about cases of COVID versus positive test, this person was not a case of COVID. This patient was a case of a broken hip that happened to have a COVID positive lab test. And we don't count that as a COVID inpatient bed, so to speak. And so that's important. And I don't think we're deliberately inflating, but we have to have some accuracy for scientific reasons to know what the penetrance of COVID is in the community. It allows me to know that just because someone doesn't appear to be sick doesn't mean they could not be spreading or shedding the virus. And that's the reason we're telling you to wear those doggone masks. Again, and if you let's get kind of gross about it, if this person were to have a fatal outcome, the 99-year-old with a fractured hip, which is substantially a risk, and this is what doctors have also been accused of doing, of inflating death certificates. If I signed the death certificate for that one where the 99-year-old has a fracture from a fall and a broken hip as a cause of death, I'm not going to contribute COVID to the cause of death there. And that's where you want to be careful that we're not misrepresenting things. I don't have any document or scientific evidence that we're inflating things, but we're being scientists and telling you the truth.
Thank you. Holly Cervini submitted this question, Dr. Harmon, regarding viral load. Can you get just a little COVID or a lot if, let's say, you work in a hospital environment, and can that affect how hard it hits you, or is that fake news?
Oh, that's a good question. And I don't know when you use the term fake, but is it misdirected news? We do think viral load makes a difference. It absolutely does. That's why we talk about, and I talked about surface decontaminations. I've done a lot of reporting to the various media, and I've done some reading of the media. I don't do research. I read it. I mean, I'm a busy practicing doctor, but I get daily readings from respected scientists like the Journal of the AMA and the New England Journal of Medicine, the two leading publications in science in the country and in the world right now. And we talk about how viruses may be maintained on hard surfaces versus paper surfaces versus your groceries versus your mail. And there may be a few particles of the coronavirus on your mail. There may be some on your bananas, on the peels of your oranges and things, and on your phones and things if you give it to a COVID positive person and get it back. But those viruses that are there can be tested and shown in the laboratory. We don't find that they're very infectious, as it were. You don't get enough viruses there from there unless you were to, maybe rub all over the phone and then rub your mouth and nose and try to really force yourself to get a viral load internally. So the amount of virus particles on the surfaces are probably not enough to get into your mucous membranes and your nasal passages and your lungs. We do tell you to wash them down and wipe them down and decontaminate, but we don't have a lot of documented spread from a cell phone to a patient. What we get spread from is person to person, where someone coughs, sneezes, achoo, takes the tissue, doesn't wash their hands, spreads the particles more than 3 feet from them, and you're out inside that 6 feet social distancing radius, then you can get some of those germs breathed into your air, into your airways, into your nasal passages, into your lungs.
Uh-oh. Dr. Harmon, you're frozen. Uh-oh. I don't think I did anything. I hope I didn't. Dr. Harmon, if you can hear me, we're not hearing you. So I don't know if you need to go out and come back in to Zoom.
Let me try and reach him on the phone. He probably won't answer the phone.
How about that?
Here he is. Here he is. You got it.
Perfect.
I was kicked off, okay? The COVID virus probably, Holly, we were talking about viral load, and probably the virus became too much of a bandwidth. That's my story, and I'm sticking to it.
Gotcha. Well, I have another question for you submitted by Troy Kaz. In the beginning, I understand a COVID positive person was deemed contagious for 14 days from the exposure date. Is that accurate, or has that changed?
No, and Troy, that's a good question. Right now, the official recommendation from the CDC, and pretty much supported by DHEC, Department of Health and Environmental Control of South Carolina, is that we ask people to not so much hibernate, but to quarantine themselves and stay in self-quarantine and not go back to work for 14 days after exposure, or 14 days after symptoms begin, before you return to work or leave that quarantine. The 14 days is from CDC and from DHEC is based upon scientific evidence. Most of the time, when you start to shed the virus, this virus shedding is almost always gone by 7 to 8 days afterwards. So we tack another couple of days on and say between 10 and 14 days. If you're 72 hours without symptoms, such as no fever, without having to take Tylenol or ibuprofen or something to what we call an antipyretic, if you can go 3 days without any symptoms, 3 days without any fever, and at least 10 to 14 days since the onset of symptoms, you're presumed to no longer be shedding the virus, and you can go back to work. You should still do social distancing, wash your hands, wear a mask, the 3 W's: wear a mask, wash your hands, watch your distance. Those are the things you need to do. But the 14-day paradigm is pretty well standard across the industry. And healthcare workers, if we have someone who tests positive and is asymptomatic, we require 10 to 14 days, generally 10 days in the absence of any symptoms, before they can return to work.
Great, thank you. Kathy just submitted a question. Can you help us better understand herd immunity?
Yes, very good point there. And one of the things we think about, this herd immunity is what has protected us for probably a century now, since the mid 1900s, when we started having vaccines come out, and we could come up with vaccines to protect us from the childhood diseases. We really had more vaccines in the mid 1900s, if you recall, the middle of the 20th century. Not everybody on this call is old enough to remember childhood diseases like measles, mumps, chickenpox, German measles, and we even had a disease called the fifth disease, where you had a virus that caused you to have a rash, a little runny nose, and congestion. And it was not measles, mumps, rubella, or German measles, or chickenpox rather, and it was the fifth disease of childhood. So we actually call it the fifth disease. But now we have vaccines for almost all of these things, and not everybody got the vaccines, but when you got enough, let's say 80% of the population had the vaccination, then you had herd immunity. And so you could get by with no one else spreading the mumps or the measles and chickenpox, because you had a very small population that was eligible to get the germ, and that everybody else protected the herd from becoming infected with it. So that's what we consider herd immunity. One of the things we're talking about now, there may be, well, we test, Tidelands has tested, I heard on the radio, like 17,000 folks here in the last couple of weeks. And we're looking at about an 18 to 21% positive rate among those folks. And these folks that are testing are not all symptomatic. Most of them are just curious. And they come by, they drive through, and they sit for a couple hours and they get tested. We're seeing the general population to have about 18 to 21% infectivity. So we're a long way away from herd immunity right now in our local community and even state population.
Holly submitted another question. Do you feel confident that our tests are accurate? There are urban legends of people sending tests in that have made no contact with them whatsoever, and they all come back positive. Also, do we have any testing methods that you feel more confident about than others?
Well, that's a real good question. Clearly, that's one of our limiting factors for being able to handle, manage, and predict this disease outbreak, this pandemic. The disease got ahead of our testing capabilities, no question of it. Right now, the gold standard for testing is the hose up the nose, I call it, the nasal swab. It's a PCR, which stands for polymerase chain reaction. I think I got that right. Remember, I'm a country doctor, not a Anthony Fauci here and a PhD in research, but it tests RNA fragment, which is ribonucleic acid. It's a nasal swab. It is probably 60 to 70% accurate. So there's as much as a 30% false negative rate. You could have the germ in your system, in your body, and despite having what we call a nasal swab test, you could still, it could show up negative. And the reason for that is kind of multifactorial. We talked about the viral load. If you don't have a high viral load at the time when we do that nasal swab, and I personally have done on folks maybe 500 of these, because I've been in a lot of these mass testing events, enough to get hand and finger cramps from testing all the time. But anyway, if you don't get it exactly right and you don't hold it in the nose for 10 seconds, which is a long time if you ever had a stick in your nose, one potato, two potato, by the time you get 10 potatoes, you want to grab my hand and rip it out. And then they tried. I mean, I can't hold any ill will towards them because it's tough. It feels it's at the base of your brain, literally. But anyway, if you don't get a good test, collected specimen, then it might not show positive. If we don't take it and put it in a cooler, which we do at these test facilities, with some ice, it can it'll die. The virus could die or something, or the media could break down. So you can lose the test validity there. The test itself is still not nearly going to be 100%. Most tests are only about 90%. The standard flu tests that we do only about 80% accurate anyway when we do flu tests. So this is almost as good as the standard flu test that we're doing anyway, and or the strep throat testing. This is a pretty good standard. So yeah, these tests aren't the best, the current gold standard tests, but it's still the best we're doing. The other tests we can talk about, and you asked, do I have favorites? Right now, the favorite is still the national standard, which is the nasal swab PCR test. There's a buccal mucosa, BUCCAL mucosa test, where you swab, instead of the nose, you swab the inside of the cheek, trying to get a viral load there. Again, it's dependent on how much virus is in your mouth versus in your nasal passages. We think the viruses are more resonant in the nasal passages. There's a spit test, a saliva test. You get up first thing in the morning before you brush your teeth or do anything, and you spit into a cup, you seal it up, and we test it that way. The same idea that's the swab. That's probably only about 50 or 60% accurate versus 70% such as the other one, but that's an alternative test that CDC and DHEC may accept. There's a blood test called a serology test, a test for antibodies, and they test for up to 3 antibodies. It's a blood test. We can show the presence or absence of antibodies. It takes about a minimum of 2 weeks after you get infected for those antibodies to show up. So it's more of a what you used to have test versus what you currently have test. And having the presence of antibodies mean you were exposed to the virus and developed an immune response, but it doesn't imply that you had to have been sick. You could have been asymptomatic, and also doesn't convey immunity. So we really don't know what to do. Again, scientists are just now collecting enough data and putting it through these computers so that we can get an idea of what relative immunity you might have. And there is a point of care test where you can swab somebody, put it into a nasal, into a media, stir it up, and wait for a colorimetric change, and you can get a result on that in about 10 minutes. That's available too at certain places. Some of the local vendors have that, believe it or not, and MUSC has that. They're not quite, we don't know the scientific accuracy. They are not absolutely validated. They are licensed by the FDA and what's called an emergency use authorization, EUA. When people call me up and they say, Dr. Harmon, I've got to fly to Alaska. Alaska says I want to test within 72 hours to show that I don't have to be in 2 weeks of quarantine in Alaska, and some states have similar things. You know, I tell them I'd go to one of the rapid testing events, get tested, and you'll get them within 48 to 72 hours. And if you need to pay $100 to get one of these office-based, retail-based tests where they'll swab and give you a result in 10 minutes, I think they're as good as anything. They're not the gold standard, but they give you enough clinical information that lets you pass immigration standards, lets you get on the airplane, lets you get off the airplane. And as I just got through saying, we're only looking at about 2/3 accurate anyway, but non-zero data is important. A little bit of knowledge is important. What you cannot presume, though, is that you're immune to it just because you have an antibody, or if your test is negative, don't mean you can't pick it up in 3 days. Those point of care tests are just showing the viral loads that we talked about a minute ago at the time you're tested. And it can be 3 days later that you show you have enough viral load to test positive. That's kind of scary to have so much unanswered information to you, but that's kind of the best we're going with right now.
That kind of leads into Trish's question. She said, I've heard some people say they have not gotten a fever, but have tested positive. Yet temperature checks are one of the things places are using to clear people for entry. Do temperature checks work?
Absolutely. You know, and I used it for the last couple of months. I've got one of these temperature guns. It's a little infrared gun, and you point it at someone's forehead and you get your temperature. Mine's 97.8 right now, which is good. It needs to be less than 99. And I was testing all of my colleagues in the office spaces, and we were testing the temperature of everybody going into any Tidelands Health facility. We're probably still doing that. However, we've learned that temperature can be a misleading indicator. However, we still have to do some scanning. It's not like we can do a CT scan or a Star Trek level scanner on every visitor or patient or worker in our healthcare facilities right now. So the temperatures scans are probably the best we have available. The challenge is that there are other symptoms of COVID infection, including active infection, that don't necessarily bring one's fever up or temperature up. Cough, shortness of breath, diarrhea, loss of taste or smell, headache, all these things have now become almost as common as a fever, as a symptom of are a sign of a COVID infection. And again, as many as 25 to 30% of those that actually have and may be spreading the virus are absolutely asymptomatic with no symptoms whatsoever.
Okay, thank you. Holly asked, what is the truth about getting the virus again once you have had it?
There are anecdotes, and I don't know that I can tell you there are scientific papers about it. There are anecdotes where someone said, you know, I had the virus in April. I'm pretty sure I had it. Now I've got it for sure here. And I don't know if they really had it or not. The science has a few limited reports of folks having a second bout of COVID. It's not clear whether the patient described in the literature or the patient described here locally actually ever got over the case of COVID. I will tell you again, since I'm a practicing doctor, I can tell you what I've seen. I've had 1 or 2 cases of patients who were in the hospital system, let's say 60 to 70 years of age, had some chronic diseases, pre-existing conditions like diabetes, respiratory disease, high blood pressure, heart disease, seem to be responding well. Were sent home after 5 to 10 days in the hospital, treated with supportive care, maybe with more specific treatments that I'll talk about at some point, but sent home and then came back about a week or 2 later, ill again and having more trouble breathing. Remember, one of these things about COVID is that it affects your airways and your blood vessels. It's a virus that goes straight to the lungs, and it's an inflammation type virus. It's an inflammatory virus that affects not only your lungs, but the blood vessels in your lungs. And the biggest blood vessel in your body is the heart, and it can affect your heart. We now see as many as half the patients with serious COVID infections having not only lung problems, but cardiovascular problems, heart and blood vessel problems. And so you might get sequelae, which means long-acting side effects and illness from the original COVID infection and appear to have a second bout, when in reality, you're probably just having more complications from the original.
So with us being business folks and potentially some of us having employees in an office, what are some products that may help businesses minimize the risk for their employees and customers? Reports state that ozone has been proved to work against coronavirus and SARS. Has it shown to help, and is it currently being used in the medical industry to help with COVID-19?
Well, you know, that borders on, and again, this reason these seminars are very important. You're having this meeting today, and the reason it's important for the media to interview folks like myself who are in the trenches every day and getting the scientists to talk about what we call valid scientific data with peer-reviewed evidence. Ozone doesn't help anything. That's an urban legend there. That's one of those things that I wouldn't say fake news, and no one's trying to deliberately mislead anybody, but ozone is not of benefit. Ozone, I think, is part of some sterilization process, but it does not hold itself out and have any scientific validity in killing the SARS-CoV-2 virus, okay, or coronavirus.
Okay, thank you. I'm looking at our questions that we submitted to you, Dr. Harmon.
Yeah, let me tell you what I thought was interesting too. One person asked, how long does the COVID-19 virus live on paper? Well, most of the times when you say live, it can be obtained or scraped off of the paper or cardboard or mail or Amazon delivery or stuff that shows up on your doorstep. It can be scraped up for maybe, let's say, an hour afterward on what we call a porous surface. But the viral load that sticks on that is so low as to be not contagious, I guess is what I would say. What I've told people to do, if you get stuff delivered, if you take your groceries home, you can set them on a table. You can wash your hands with the decontaminated solution or just soap and water for 20 seconds. But there's just been no documented evidence of somebody getting COVID from the mail or from a bag of groceries. So even though you can detect it in scientific petri dishes, doesn't mean it's enough of a load to make you sick. So, and in your businesses, you need to wipe down the surfaces between customers and things like that. Wipe them down with a decontaminant, cleansing solution. Standard household cleansing solution is fine. Doesn't have to be, a Clorox wipe. It can just be a standard decontaminating bactericidal spray solution. What I see in your offices is, and you're already seeing, is you maintain social distancing between yourselves, your employees, and the public, and other employees too. In a closed indoor space, the employees need to be socially distanced. They should wear masks when they're in indoor space. You try to get outside air in and not just have recycled indoor air. That's the problem with elevators and commuter trains in the high density areas, buses, airplanes. They use recycled air and not outside air in a high density environment. We're blessed here. Most of us can work and have your customers come in and out of your building without going through an elevator. That the only elevators we have are places like hospitals for the most part, and the small elevators in our few facilities with second, third floors. Remember, we had a height requirement in Georgetown County, so the tallest building is the hospital right now.
Mm-hmm. Mm-hmm. So once we have a vaccine, Dr. Harmon, will we really actually be able to go back to normal, whatever back to normal is going to be, and stop wearing the masks and social distancing? Will the vaccine eradicate the virus, or will we need to continue to get the vaccine until herd immunity kicks in?
Well, we're going to get a vaccine. In fact, I think the underlying question there is, when can we go back to normal? And the answer is when we have a vaccine. Absent a vaccine, it's going to be really hard to go back to normal. The reason we can have a pre-COVID normal is because we had vaccines against the killer diseases. We had a vaccine for polio. If you remember, the Salk vaccine was the shot. Everybody hated that. Kids hated that. I don't think anybody's old enough, but I remember getting those painful polio shots. And I thought, it used the quote, I died and gone to heaven when they came up with the sugar cube you could take with a Saber vaccine for polio. But if we didn't have a vaccine for polio, we were threatening closing the schools down in the 50s because polio was a killer of kids. And when we developed a vaccine, education became much more normal. And I think what we're looking for now is this vaccine that we're hoping to be available by the end of the calendar year, first part of 2021. And we'll be back to very close to normal then too. The vaccine has to be probably at least 50% effective. We put a lot of stake in the current vaccines, the flu vaccine, and I encourage you to get your flu shots. I encourage you to get the pneumonia shots. I tell you to get that when you come into our offices. And folks sometimes defer. I encourage you to get a shingles vaccine because it seems to be very effective. But if we get enough vaccine that has at least 50% effectiveness, we're going to be able to get close to that herd immunity we talk about when we have a large vaccinated population. The current flu vaccines now only about 50% effective many seasons. Sometimes they're as much as 70 or 80% effective. But the flu vaccines prevent us from having flu pandemics right now, so they seem to work. Will we have an era where we don't wear a mask? I think so. I believe we can get back to it. Will we have an era where we can resume being social animals and go out to eat without having to wear a mask? I think so. Will we have an improved awareness of washing our hands? Yep. I believe we're going to be more aware of washing our hands. We should have been doing that all along. It's just common sense that we wash our hands after we do certain functions, after being in communal areas. And we probably didn't wash our hands enough pre-COVID. I know healthcare workers and many folks in the food service industry wash their hands a lot. Hence the term dishpan hands, or they make so many emollients to help us after we wash our hands so many times in the healthcare industry. But I think you'll find more and more public washing their hands in the new normal.
So I'm going to, Kathy, I'm going to jump to Wendy's question because this kind of goes along that line. It's, can therapeutics help in place or until vaccine is available?
Well, therapeutics are treatment. You're exactly right. And what we're doing now, and I think that's a good question. I was going to answer that off the sheet. What treatments are we doing? You heard a lot of media buzz about hydroxychloroquine, which is an anti-malarial drug that some folks, including the president, took for a period of time, and talk about it now. I'll tell you what we do now. If if you come into our hospital with a COVID diagnosis, and again, I've had some of these quite recently that I've taken care of. Someone comes in there with what usually brings a patient to the hospital is they're short of breath. They have a hard time breathing. They can't keep a conversation up. They may have a fever. Typically could have a 101 fever, but really they're short of breath. They're having a hard time carrying on a conversation, and they're struggling to breathe a little bit. They don't necessarily have chest pain. They don't have chills. They may have some muscle aches. They have a low-grade fever, perhaps, as I said, 99 to 101, and they may be coughing. So what we do is we bring them in. Of course, they usually call us. We ask them to call so that we know they're coming. We try to meet them out in the parking lot or meet them in the doorway. If they don't already have a mask, we give them one to put on. That way, we're protected from their germs, we hope, and other people that they interact with along the way will do that. And we'll measure their oxygen deficit with a little pulse oximeter. We'll check their temperature, of course, with the thermometer, but we'll measure their oxygen saturation. And if it's below 90%, we'll give them supplemental oxygen. The normal oxygen saturation is 95. But if you get into the high 80s, then we start adding oxygen to you. We put either a mask on your little cannula in the nose, and we support you. And if we diagnose you with coronavirus and you need oxygen, then we think about giving you therapy. What we give you is a steroid. Remember, I talked about coronavirus being an inflammation type disease. It inflames the lining of your lung, and it inflames the lining of your blood vessels in your heart, and it causes a substantial amount of inflammation and interferes with the normal function of the air cells in your lung and the blood cells in your body and in the blood vessels. So we give you an anti-inflammatory medication. In this case, it's what's called a steroid. The one that's got most of the publication and press is dexamethasone or Decadron. So we'll give you Decadron, usually in an IV or maybe a pill, even while we're waiting to see if your COVID test is positive, because Decadron doesn't hurt you. It's pretty safe. It's what it does. It acts like a boost to your adrenal gland. It's kind of a boost of adrenaline, if you think about it. Your adrenal glands are what help you with the inflammatory response anyway. You get a boost of what we call adrenal corticosteroids. Big word, but it's like an adrenal gland on steroids, because it is a steroid. But the dexamethasone helps. We may also give you, believe it or not, a medication called thiamine, thiamine, which is a kind of a booster too to help protect you. So we'll give you thiamine orally or IV. And then we'll probably give you an antibiotic called azithromycin or Zithromax if you don't have a cardiac rhythm problem that would contraindicate that. And if you turn out to have COVID with that blood test we talk about, or not with the blood test in this case, but with the nasal swab we talk about, and we can get it back within a couple of hours. It takes us about 4 hours in a very rapid, limited access that we've got, a research-based test we can do on. If we know within 4 hours of the admission, within 8 hours of admission, that you're coronavirus positive, you've been sick less than 14 days, we're not going to have to put you on the ventilator. We'll use this experimental drug that's an antivirus called remdesivir, RDV. And we have a limited amount of those in the state. They seem to work. It's a 6-dose, 5-day therapy in an IV format, and it seems to help. I mentioned that we've had a lot of cases and a lot of infected patients in the hospital, but knock on wood, we don't have a substantial increase in the death rate. We've had a few more, but we're still managing, to your point here, to the questioner's point, we're managing to have a lot of treatments, a lot of therapeutics available that seem to help. They're not, they're not FDA approved, but they're FDA authorized right now. We seem to be using and gathering data that this remdesivir helps.
Kathy, I haven't forgot your question, but I am going to ask Tricia's question because it's along this line. I saw that some hospitals and airlines are using UV lights to sanitize. How effective is this?
Well, that's not UV light. It's like the ozone question ago. Does it kill things? We think UV light probably has more scientific validity than ozone. Ozone is used to sterilize things, but not necessarily particular for the coronavirus. But the UV light, we think it may help. Okay, we really do. So I can't speak against it. It doesn't hurt very much. I tell you what's kind of scary, and I've done a little report on this one time. When you talk about sanitizing and cleaning things, you know, for a long time we've talked about using these air hot air dryers to dry your hands in public restrooms and all after you wash your hands after using the restroom facility. You've got these hair dryers and hair blowers. The studies have actually shown that that may spread the germs of coronavirus more because it blows it all over the area, and it doesn't so much aerosolize, but it disperses the germs in a closed restroom environment more than it would be if you just washed your hands and dried them on paper towels. So, you know, what may be intuitive to a lot of folks is a non-contact way to dry your hands. It may actually spread the germ more. So for goodness sake, wear those masks in the public restroom. But it's scary about that, how that works. UV light, we're not investing in UV light right now. We're using the standard decontamination procedures. I don't know that UV light's going to take hold in a coronavirus environment.
Okay, thank you. So Kathy asked Dr. Harmon, our school district is trying to decide how kids return to school on September 8th.
Mhm.
It may be virtually and move to a hybrid model. Is it safe to assume kids will overcome this virus easier than adults?
It is safe to assume that, and that with the school district opening, gee, that's it's not a dilemma, it's a conundrum. The superintendent, the school board have their hands full trying to make the best decision for all parties involved. We do know that kids they're not immune, but they're not very susceptible to the ravages of this disease. There are a handful that get an inflammatory syndrome that apparently there's been one in our state. It's an inflammatory syndrome that looks like a disease called Kawasaki disease. We talked about how the coronavirus affects the blood vessels. On some rare children, 1.5 million maybe, it could infect a heart and blood vessel of an infected child. It's heartbreaking if it occurs because there's not a good treatment for it. But for the most part, children are very resilient. Their youth protects them from any manner of diseases, and this is one of them. That does not say that they cannot be contagious, however. That's our challenge, that the children in our school systems, even though they're resilient to the illness from the disease, they could be asymptomatic carriers. They could then carry it home to their grandparents like me, if it's my grandkids, and they could be a transmitter within the community. That's the yin and the yang of trying to decide of opening schools with healthy kids and the kids probably not being that impacted from it. And the school teachers are going to have some concerns, and they rightfully should, because some of them are going to have some substantial risk factors. And it's hard to distance yourself from a 6-year-old or an 8-year-old whenever they have any manner of needs that you've got to be right down there with them. We do encourage, and the school district has very directive guidance from the Department of Education, the State Department of Education, and the DHEC. And they have recommendation from the American Academy of Pediatrics and things like that. But I think each school district has been kind of tasked to make their own decisions. Each school board's having to make their own decisions. And we are blessed to have a very good school district and very good school board. So I'm going to support what they decide to do. Not only could the teachers become sick, the parents or grandparents at home with the kids, but so could the workers, the school nurses, the sanitation workers, the security officers, the maintenance folks. All of them are going to be at risk. So we're going to, all the recommendations are for children as young as 3 years of age to wear a mask at all times, unless they have a respiratory reason not to, maybe some type of congenital problem or serious asthma that may restrict their ability to breathe. Otherwise, we're going to ask that all kids in the schools wear masks.
So I'm curious about what you think about this. I've thought with the reverse of COVID, the hotspots now being in the Southeast versus the Northeast, as it earlier started, could some of that transmission, that spike in COVID on the Southeast, be caused by people from the Northeast that are vacationing in our beautiful Southeastern counties and cities and beaches?
Well, it could be in theory. I think the reality is that we have contact tracing. The Department of Health Education, Environmental Control, DHEC, is doing contact tracing. I don't know what the statistics are showing them. I think in theory that could be because we have more visitors to the area, but I think the reality is we don't have enough visitors. We have we're not nearly as you're the vendors and you're the business industry. I bet you're not as busy as you are in this normal time of the year. So we might say there are some that could have brought the disease to us. I think it's just the normal spread of opening up the businesses and getting um, folks to probably not behave as well as the authorities have asked them to. As I said, well over a month ago, I started wearing a mask, and I was the only one in many facilities. Now, when you go, almost everybody's got a mask on. That's good. So we're starting to march to the common drummers right now and wear our mask, and I think that will limit and mitigate transmission of the disease. I think Walt Kelly and Pogo says that we've met the cause, and it's us. It's not outsiders that are causing us to transmit the disease. This is a human-to-human transmission, and we have just had a lot of human contact, and we need to kind of go back to my advice to use the 3 W's again. Wash, wear, and watch your distance, as it were.
So we have 2 more questions, Dr. Harmon, and then that'll probably get us right to where you have to leave us for your next meeting. So the next question from Troy Kaz. Hold on a second. Here we go. Regarding office ventilation, does it help to keep the AC fan running constantly, particularly in offices with known COVID-19 exposure?
Well, it's a good environmental engineering question, Troy. I don't have a lot of environmental engineering background, but I would tell you, closed spaces, recirculated air, I do think that's going to be a little more at risk. That's one of the problems we have, as I said, with public transportation, with elevators, closed spaces and recirculated air. That's why the dining facilities originally opened up, that you could be outside. You've got dispersal of the viral load that we talked about. If you recirculate them in air conditioning, I don't think we've had a good scientific study, but it cannot necessarily help, is what I would suggest. It'd be best to have some outside ventilation to kind of clear the air, literally, if one can do that. That's why outside dining is better. Outside facilities, when you're exercising and when you're running on the beach, we don't tell you to wear a mask. Then when you're riding your bike down the street, we don't tell you to wear a mask. When you're just walking. But when you're in an indoor exercise facility, such as some of our facilities and fitness clubs in the area, want you to wear a mask because you're indoors then. So I don't think it has that much to do whether it's cold air or warm air. I just think that the more circulation of air with outside refreshing air, you're better off.
And this will be our last question from Eric and actually it's 2 questions. What would you attribute the drop and stabilization of the death rate to? And with cases spiking in the South, we aren't close to New York's death rate. Is it treatment techniques that are helping that?
Eric, we don't know. I did tout how we've been remarkably able to keep, and the classic epitome is if it's your parent or your death, it's a big deal. And it is. Every death is important. I never want to minimize the loved ones that we lose, because I've lost friends and extended family for many reasons over the last couple of months, and all of us have. We've had coworkers that have been sick. One of the issues we talk about at Tidelands and other broadcasts and other media broadcasts is we have the room, but we don't have the capabilities. That's why we've had some help from the National Guard experts, and thank goodness for volunteers like them who do help their community and give back. But I think your question is a very appropriate one. I think we're learning more about it. In mid-March, when we started closing our businesses on March the 13th and responding to just a handful of diseases in our community then, we really didn't know how to treat it. We didn't have the remdesivir. We didn't know to use the dexamethasone. We've learned so much more. We put people more rapidly on the ventilators now. And believe it or not, we're starting to think that the ventilators, even though it appears to be a very good treatment, there's some scientific evidence that maybe that exacerbates the disease. And so we try to delay putting a person on a ventilator. We use a lot more of what we call extracorporeal type ventilation settings. We use BiPAP, we use CPAP, but we don't actively put a tube into their lungs. We use a lot of mechanical pumping to help them breathe. We use this new treatment called remdesivir, which is very beneficial. We also have what we call convalescent plasma, because now we've got folks that have donated their antibodies, as it were, their plasma, through the American Red Cross, and we can use that as one of our treatment options. So we have more arrows in our quiver now to use in the advanced cases of coronavirus. And I think all of that contributes to a lower death rate.
Dr. Harmon, we greatly appreciate your time. This has been a hugely helpful session for us. I know all of us got some really great education today. And thank you for all your work and your staff at Tidelands Hospital for just the uncompromising spirit and the effort to help our community.
You know, as I said, this is an honor to be asked. Doctors like to have their opinion respected, you know, boost our ego. Not that we need ego boost, we tend to have it anyway. But I'll tell you, we appreciate people listening to us, asking our opinion, and then in the best of worlds, take our advice. You know, one of the things a lot of you may have heard me say, my advice is to take my advice. It's not given. It's not given randomly. It's not given without scientific thought. I aggravate my kids, now my grandkids, and my wife sometimes, and say, I do everything with a purpose. I try not to be too random in my decisions. I try to think it through as a scientist before I decide to do this therapy or this treatment or make that decision. But the science now tells what we should do. We have been given directions on how to open up our businesses, how to, there are even some options for opening up schools, and that's being very scientifically and well thought out in the process with our school board and our school district in our entire country about how to open our business and our schools. But look at the science. Have media meetings like this. Read the valid scientific literature to know what type of mask to wear, what type of decontaminant you should apply on your surfaces, what medications you should think about. All those things are important. We can get through this. I do appreciate your organization being part of the solution too. Thank you.
Thank you.
Thank you, Dr. Harmon.
Thanks, everybody. Have a great day.
Thank y'all.
Bye.
Bye-bye all.